Everyone, I'm Dr. Laura Lacher, and welcome to Medical Grand Rounds. We'll get started with a few announcements about our upcoming weeks and some logistics before introducing today's speaker. So just as a reminder, next week we have our annual Holtzgang Lectureship in Ethics, and we'll be hearing from Dr. Michael McCarthy. This talk will be available live here at St. Vincent on Tuesday and also live at Providence, Portland on Wednesday. So please be sure to join that special lectureship next week. And then in 2 weeks, there will actually be no grand rounds on Tuesday, October 10th. We'd like you to save your time and energy to support the Providence Portland internal medicine residents who will be preparing and presenting work for the Oregon ACP meeting on Wednesday in the Providence Portland Social Room. So next week, come in person, 2 weeks, Wednesday only. And again, Grand Rounds is now a joint effort between Providence St. Vincent and Providence Portland. We're really excited to be a live audience when possible. And each week the invite will explain where Grand Rounds will be or whether it will occasionally be only virtual. Grand Rounds is always available live virtual through Teams Live. And you can earn CME credit for watching in any of these ways here with us in person, live virtual, or recording of the session. And that video is always available at the same link as the invite to Grand Rounds. So today I'll be monitoring the Q&A for our virtual audience. Please go ahead and post any comments or any questions, and I will be mostly holding those to ask our speaker as time permits at the end. And now I am delighted to introduce today's speaker. We are joined by Dr. Jim Laidler. He is the medical director for Great Circle Recovery, which is funded by the Confederated Tribes of Grand Ronde. Dr. Laidler did residency in anesthesia at University of Illinois, Chicago, and more recently, a PhD in microbiology at Portland State University. Dr. Laidler has been working in addiction medicine for the past 10 years, and he is board certified in both anesthesiology and addiction medicine. We're so delighted for him to lend his expertise today. Thanks, Dr. Laidler.
Thank you. And thanks everyone for being here, either both live and virtually. Anyway, so today's talk will be about benzodiazepine dependence and withdrawal. So I thought first just go over some basics about benzodiazepines. I always like to start with the history, which they're first introduced way back in 1955, and the first one was chlordiazepoxide or Librium. At that time, it was safer than what people were using, which was barbiturates. It was initially thought to be non-habit forming, which is kind of a recurring theme in all addiction medicine. And ironically, the first benzodiazepine withdrawal seizure reported in the literature is from 1961. So it didn't take them too long to get into trouble with that. There are also some benzodiazepine-like drugs. A lot of people think of as benzodiazepines because they basically work in the same way. Those are the imidazopyridines, like, actually I misspelled zolpidem, there should be an L there, and zaleplon, which zaleplon isn't used in the US, I don't believe. And there are also cyclopyrrolones like zopiclone and esopiclone, which I think is trade name, isn't that Lunesta? Anyway, they work on the same receptors as the benzodiazepines. They work in the same way. The only difference is that some of them are limited to the subtypes where the receptors they interact with. And here's some for the organic chemistry nerds like me. You've got, see if I got my laser here. So this is sort of the generic benzodiazepine, and this little 7-membered ring with the 2 nitrogens for fun reference is the diazepine ring. So if you see that, that's what it is. And you can see there down, zopiclone and zolpidem are very different structure-wise. All right, so the GABA receptor basically is a chloride channel. It works to hyperpolarize the cell when it's open. Chloride comes in, so it hyperpolarizes the cell and makes it harder to discharge. It exists as what's called a heteropentamer. There's 5 subunits. They're not all identical. There's 2 alpha, 2 beta, and 1 other subunit, which in most the ones we're thinking about is going to be a gamma subunit. The GABA itself binds between the alpha and beta subunits, and benzodiazepine binding site is between the alpha and gamma subunits. As you can see here, there's 2 GABA sites and 1 benzodiazepine site. So the benzodiazepines and other, imidazopyridines and all those, They don't actually activate the GABA receptor, except at really, really high doses, which are not physiologically relevant. But they act as positive allosteric modulators, which is they make the receptor more sensitive to GABA. Interestingly enough, barbiturates, and this will become important a little bit later, also work as positive allosteric modulators, but they work on a little bit different way, whereas the benzodiazepines work by increasing sensitivity to GABA. The barbiturates actually increase the duration the channel is open. So the two of them can work synergistically. Yeah, so this, as I said, this will become important later. Anyway, they only, just for those of you who are neurophysiologists out there, they only affect the synaptic or phasic GABA A receptors. They don't work on the extrasynaptic or tonic GABA A receptors, and they have no effect on the GABA B receptors, which are a completely different animal. Most are nonspecific, meaning they don't particularly care about what different subunits are making up the receptor, except, again, it becomes important, zolpidem and zaleplon are very specific for the alpha-1 subunit. They don't really bind well to GABA receptors that have other alpha subunits. And zopicolone and esopicolone are slightly selective for alpha-1 and alpha-5. All right, so what's the scope of the issue? We got two issues actually when it comes to benzodiazepine dependence, and one is prescription benzodiazepines. I know from where I work, I certainly get a chance to see, because I do PDMP searches on all of our patients, and there are a lot of folks out there, hopefully none sitting here, who pretty much prescribe benzodiazepines like they were Skittles. And fortunately, the great majority of people are not doing that. But still, if you look at some of the studies, the number of people filling benzodiazepine prescriptions is pretty significant. I won't go into all of these, but we're somewhere between 4 and 8% of all ambulatory care visits involve a benzodiazepine prescription, which is a little bit alarming to me, because again, I tend to see the end stage of that. All right. The other side of the equation, of course, is the illicit benzodiazepines. And this sort of comes and goes, and this is a group of actually forensic laboratories that get together and share information. And they talk about NPS, that's a little jargon, it's novel psychoactive substance. So these are the sort of street benzos that are out there. Granted, most of what we're seeing currently is still garden variety, clonazepam, alprazolam, lorazepam stuff. Occasionally, diazepam still out there, still a big favorite. But there's a lot of these what I would call non-FDA approved benzodiazepines out there. Most of them you probably have never heard of, like bromazolam, which is currently very popular it's very popular in Vancouver, BC, and Seattle. It's kind of trickling its way down to Portland. You may not be familiar with bromazolam. Don't be surprised. It was actually never tested in humans, but it's being widely tested unofficially in humans right now. It's currently the #1 illicit benzodiazepine in the U.S. Prior to that, etizolam and flualprazolam were big. Again, etizolam was at least used in Europe and has been studied in humans. Flualprazolam was never studied in humans. So we've got a lot of this stuff out there, which is kind of scary, because at least with the stuff that's FDA approved, that's been studied in humans, we know what's what about it. With a lot of these, we have no idea. Again, this is just sort of reiterating that, which is the bromazolam, which is just basically alprazolam with a bromine instead of the chlorine. Just coming right off the charts right now. All right. These are some of the benzodiazepines that we're seeing on the street currently. If you'll look at that, none of these have been, actually, I think, yeah, none of these have been tested in humans, except to the extent that they're being tested illicitly. But they all work pretty much the same. and they're all causing a lot of deaths. This is from CDC Wonder. This is a death certificate reporting, and you can see over the course from 2000 to 2021, which is the last year they have complete data, it's been pretty much a linear climb. So 2021, there were almost 13,000 deaths from benzodiazepine overdose. So that kind of gives you the scope of the issue there. And just to kind of break this up into a sort of ethnic groups, currently the most susceptible, the most affected group are the Caucasian or white people in the United States, followed by Native American, Black, etc. This is interesting in a couple of reasons. One is you notice this is in deaths per 100,000, so we're about 5 deaths per 100,000. I'm going to briefly just show you the same information for opiates, or opioids actually. So right now, opioids overall, we're talking about 25 deaths per 100,000. Native American and Black people tend to lead that, but you know, there's still quite a lot of deaths among all ethnic groups. And put some numbers on that. This is 2021. There were overall 82,000 deaths in the United States from opioids. So that's a pretty staggering number. But if you look, I'm going to flip back real quick. So if you look there on the opioids, so with benzodiazepines, we're talking about four per 100,000. And with opioids, we're talking about overall about 25 per 100,000. So benzodiazepines aren't the plague or the disaster that opioids are, but there's still a considerable contribution to deaths. And this one brings up some interesting things in that if you start looking at how many of them are associated with opioids, it kind of brings up the issue. And not surprisingly, because benzodiazepines and opioids are well known to be very synergistic in respiratory depression. And with an opioid epidemic, we're going to start seeing a lot of deaths from a combination of benzodiazepines and opioids, both because the opioids are going up and because the benzodiazepines are going up. So if anyone was thinking that benzodiazepines aren't a problem, hopefully that's not it then. All right, so let's get into more practical stuff. What about dependence tolerance? And if I like to think of dependence and tolerance as sort of being two sides of the same process. There's a little bit of difference. I mean, there's a big difference I'll talk about later, is that, you know, the dependence and addiction are generated through very different mechanisms. Because there are, you know, as we know, there are a lot of drugs that cause dependence and addiction. There's also drugs that cause addiction, but not truly dependence. Most of the stimulants are like that. I mean, people talk about a post-meth or post-cocaine crash, but there's really not true physical dependence. There's not a true abstinence syndrome. But certainly there is addiction. No one would argue that people don't become addicted to cocaine or methamphetamine. Likewise, you've got drugs that cause physical dependence but aren't really addictive, like venlafaxine. If you stop taking venlafaxine suddenly, you will definitely have a bad several days. But you also can't go down on the park blocks in Portland and find people hustling venlafaxine. It doesn't really have any addictive potential. I mean, that said, there's people abusing and using everything. All right, so the interesting thing with benzodiazepines, we think of all the different things that it does, they do, but the tolerance develops at different rates, and some of this is a little bit either controversial or questionable. One of the things, the tolerance to sedation seems to happen the most rapidly. So people who are taking it, you know, repeatedly will find that they have less and less sedation, and that's pretty much what people have experienced, is that, you know, it becomes less sedating the longer you take it. When we were using it for sleep, they found there's a great study looking at triazolam for sleep. They showed that sleep latency and the number of awakenings was back to baseline about 2 weeks after they started it. So not a tremendously effective drug for people with insomnia. Still used for insomnia. We'll get into that later. tolerance to its anticonvulsant effect is less rapid. It takes about several months for people to become tolerant to its effect as an anticonvulsant. The tolerance to amnesia develops slowly. Interesting, the benzodiazepines and the benzodiazepine-like drugs are very different in their ability to induce amnesia. It's a little sidetrack here. They actually probably, in my experience, the most potent ones, midazolam, clearly very potent for amnesia. The other one that's really potent is zolpidem or Ambien. Lots of really entertaining and sometimes tragic stories of people who have gone on Ambien binges and done amazing things and not remembered a bit. Anxiolytic tolerance, interesting. There's some studies show that it develops very slowly, but on the other hand, you'll notice that people who are taking benzodiazepines chronically for anxiety will develop rebound very quickly. Usually within a few weeks, they'll find if they stop taking the benzodiazepine, their anxiety comes back and plus. So it's even stronger than it was before they started taking. So some questions about that. As far as its reinforcing or addictive characteristics, we don't know that there's any tolerance to that. All right, sure. Mm-hmm. All right, the question's about amnesia tolerance and does it cross different drugs? And sadly, that study hasn't been done. I know sort of anecdotally from working as an anesthesiologist, people who are on chronic, alprazolam, clonazepam, things like that, they don't seem to be as affected by the sedative effects of midazolam, but the amnestic effects seem to be pretty good. Amnesia is a hard thing to test. I mean, there's not a really good. I mean, we did a study on it when I was in residency, and the process was real amusing. We can talk about later if you're interested. Anyway, so basically, the dependence manifest is sort of what I think of as an inverse effect when the drug is withdrawn. So, not surprisingly, anxiety is the most prominent when the benzodiazepines are withdrawn, followed by insomnia, muscle cramps and spasms, seizures. The mechanism of tolerance and dependence is not as clear as it is in things like opioids, but there's a couple of things we do see. One is that, if you think about the nervous system, you've got a GABA, which is a sort of inhibitory neurotransmitter, and glutamate, which is an excitatory transmitter. They're sort of in balance. And if you start making the GABA, you sort of emphasizing the GABA or enhancing the GABA, you're going to have compensatory increase in glutaminergic tone or excitatory tone. And so when you suddenly take away that sedative hypnotic drug, you're going to unmask this elevated excitatory tone. And that's the same as you see with alcohol. So it's a pretty universal mechanism of the brain trying to achieve homeostasis. So there's that. What we do see in experimental animals is one of the things is there's a change in the GABA receptor subunit composition, which is, again, why I made that point about the subunit. So in the brain, the alpha 1, 2, and 3 are more common. Alpha 4 and 6 are less common. You'll see that the subunit composition tends to shift towards the less frequent subunits in the alpha. So this wouldn't have any effect on most benzodiazepines, but if you're looking at the Z drugs, this is going to make them much less effective. So it kind of explains why the tolerance to the Z drugs, zolpidem, zopiclone, tends to happen really fast. And the other thing we see is a change in GABA receptor number and trafficking. So they seem to be pulled off the external membrane and destroyed. And how that's targeted, we know very little at this point. Probably phosphorylation, because that's how it's usually done, and ubiquitin inhalation. All right. The question then comes is, who's at risk for having withdrawal symptoms, basically, from benzodiazepines? And it's really not very clear, unfortunately, because it can be seen or not seen at a variety of different exposure levels. So you sometimes will see people who've been on chronic benzodiazepines who stop it abruptly and have no problem. Likewise, you can see people who've been on it for a fairly short period of time who, when they stop it, have a lot of problems, usually rebound anxiety. So there seems to be some heterogeneity there. Kind of a rule of thumb I use, which is that if somebody's taking diazepam 10 milligrams or its equivalent daily for 4 weeks or more, they're at risk of a benzodiazepine withdrawal seizure. Does that mean they're going to have one? No, probably not. But it's, these are people you need to start looking at. You can also see people who have seizures after I've seen case reports of 2 weeks of what seemed like fairly reasonable benzodiazepine use, and then have a withdrawal seizure. So there's, again, a lot of heterogeneity there. Plus, there's some caveats to think of. Patients tend to underreport their use, especially if they're using illicit or street benzodiazepines, for 2 reasons. One is they don't necessarily want to let you know. And number 2, they really don't know. I tell my patients that God only knows what they're getting because the person selling them doesn't. I mean, they really have no idea how much or what is in the pills they're buying. If you look at most of the Xanax that's sold on the street in Portland and in Salem is fake. It's pressed pills made by somebody in their garage. And most of them currently have fentanyl, but as far as the benzodiazepine composition, it's bromozolam, etizolam, flualprazolam, and who knows how much, floor sweepings, etc. Again, the other caveat number 2 is some patients develop dependence more quickly. I already hit street drugs. The other one is concurrent use of alcohol, because alcohol and benzodiazepines tend to have similar effects. So if somebody is drinking and using benzodiazepine, which FYI is not a good idea, they'll have more dependence when they're withdrawn. Again, with the non-approved drugs like bromozolam, flualprazolam, we have so little solid evidence of how fast and how serious the withdrawal is. All right. Okay, the onset of the withdrawal really depends a lot on the half-life of the drug. Usually about 12 to 48 hours after the last dose. The longer-acting drugs like diazepam, chlordiazepoxide, a little bit later. The really short-acting drugs, if anyone's still using triazolam, I don't think they are, probably a little bit quicker. But unlike alcohol, the peak withdrawal may not be seen for 3 to 4 days. So the person may look fine the day after, they may be shaky, they're a little anxious, but this is going to keep ramping up for about 3 to 4 days. Signs that you can look for, things like tachycardia, hypertension. When I was doing work in detox did a lot of benzodiazepine detox, that was often our first indication the person was having significant benzodiazepine withdrawal. And we were using a tapering process, and we could tell the tapering was going too fast if their blood pressure and pulse started to come up. Lateral nystagmus is an interesting thing, but that's also fairly non-specific. There's a lot of things that give lateral nystagmus. Tongue tremors. Now, with alcohol, you look for the hand tremors. With benzodiazepines, you see more of a tongue tremor or fasciculation, which is pretty unique for the benzodiazepines. Restless and irritability, also fairly non-specific. And the seizures, obviously, that's a bad sign. If you get a seizure, that's a pretty late sign of withdrawal. The incidence is low. People, even with unmanaged abrupt benzodiazepine withdrawal, only about 5% of them will have a seizure. But those seizures can be very serious. I've got one person in our Salem office who has significant anoxic brain injury from status epilepticus from a benzodiazepine withdrawal seizure. So it's not. These are seizures to be avoided. Then symptoms from somewhat inspecific: anxiety, insomnia, restlessness. One that's interesting that I found very useful, and that's tinnitus. Often patients having benzodiazepine withdrawal will manifest tinnitus. There's a caveat there. I had one patient who we couldn't figure out, and it turns out he had worked most of his life in an aircraft assembly factory, and he had just had chronic tinnitus. So that's a question you need to ask, because I forgot to ask it. Other things, tactile or visual hallucinations, feeling like something's crawling on their skin, visual disturbances. Unfortunately, a lot of people, from the movies, you kind of expect these visual hallucinations to be pink elephants or something more dramatic. It's usually initially just spots, little black spots floating through, like one person described like fruit flies. You see little fruit flies zipping through there that aren't there. Okay, for those of you who are used to using a SIWA score, which is usually used for scoring alcohol withdrawal, it's not very reliable in benzodiazepine withdrawal because the symptoms are a little bit different. Again, benzodiazepine withdrawal is much more prolonged than alcohol withdrawal. You think about alcohol withdrawal being somewhere between 3 and 10 days, and after 10 days, you're pretty much out of the woods. Benzodiazepine withdrawal is 1 to 4 weeks. And that's just the acute withdrawal. People can have increased anxiety, restlessness, insomnia for months. The symptoms are often more subtle than alcohol withdrawal, and they can easily be overlooked. People, if you're used to dealing with alcohol withdrawal, this will be a much more subtle presentation. And the other thing you need to watch for, especially if you're using a taper, benzodiazepine, or I'll talk about it later about a barbiturate taper, is to look for recrudescence of the system, the return of symptoms about 2 to 7 days after your treatment is stopped. Again, I certainly was fooled a number of times. Other people be fooled. You're thinking, okay, we're in the clear. You stop the medication, and they start having symptoms again. So one of the things I tell our residents and fellows is that alcohol withdrawal is like a great big freight train coming down the tracks. It's hard to miss. Whereas benzodiazepine withdrawal is like the max. You don't hear it coming until it hits you. Okay, so what are your treatment options? The most common one, the sort of traditional one, is a benzodiazepine taper over 2 to 4 weeks. That can either be as an inpatient, or you can do outpatient or observed. Observed is like in some sort of a treatment facility. We usually do like a 10% per day taper. So we basically start with whatever the equivalent to what they're using is, and then taper it off. You can do a benzodiazepine. I'll get into more detail on some of these later. Benzodiazepine taper plus an anticonvulsant, sort of a belt and suspenders approach. It's your benzodiazepine taper, but also start them on a anticonvulsant. The classic is valproate, which is not a real pleasant drug to use. But, levetiracetam, even gabapentin have been used. Anticonvulsant alone has been used. There have been some UK studies that show that. Long outpatient taper, 10% per week, actually shows the most long-term success, but it also has the highest dropout rate. And then there's phenobarbital taper, which I'll get into as well. Cold turkey withdrawal from benzodiazepine is really not an option. Stopping suddenly is sort of a recipe for a disaster. All right, so the benzodiazepine taper, as I said, most common method. The idea is you replace whatever they're using with a long-acting, long half-life benzodiazepine. Librium or chlorodiazepine epoxide is most common. Diazepam is probably the second most common. If you're concerned about oversedation, say elderly patients with liver disease, you could use a shorter acting drug like lorazepam. But the idea is, first you got to titrate up in the first, preferably 12 to 24 hours, but 24 to 48 hours to get them to control the symptoms as they start coming on. I mean, you can sort of guess if the patient's using prescription benzodiazepines and you trust what they're telling you, you can just give them the equivalent amount, titrate, split over several doses. But probably the most common and the most effective way I've found is to start with like half of what you think they're using and then titrate in as their symptoms come on. So this requires that they be someplace where you can monitor them. This is not a sort of thing you could do at home. So again, tapering off after 10 to 14 days, usually about 10% per day or 25% every 3 days if you're going to do this as an outpatient. What I usually do is put what I call a 4 to 7 day tail of an evening dose of whatever the smallest amount you can find. Next most common thing is to add basically an anticonvulsant, where you start with do the benzodiazepine taper, but just as I said, for a belt and suspenders approach, you add an anticonvulsant to reduce the risk of seizures. I would probably do this in someone who had a history of either alcohol or benzodiazepine withdrawal seizures, because of the kindling phenomenon, where having a seizure makes them more likely to have a subsequent seizure. Traditional one is divalproate, valproic acid. Very effective, very unpleasant side effects, lots of liver issues, kind of becoming a paleopharmaceutical at this point. Carbamazepine, also effective, also lots of side effects. Seeing more and more people using levetiracetam or Keppra and lamotrigine. Interestingly, gabapentin, although it's not a tremendously effective anticonvulsant as a solo treatment, there's been a lot of studies that show that it's been very effective as an adjunct. Again, I think some of this may be lacking. The power of the studies is somewhat inadequate to show seizures, because even untreated, the incidence of seizures is 5% or less. Basically, if you're going to do that, dose the same as you would for epilepsy monotherapy for that drug. And then, so very empirically, I usually would just continue for 30 days and either taper or stop, depending on your particular preference and the medication. All right. The anticonvulsant alone, I have never actually done, because I simply just don't have the guts to do that. But there are a lot of studies out of the UK using either valproic acid or gabapentin. They say it's very effective, but one of the things most of the studies say is that there's a high dropout rate, because patients, not surprisingly, their anxiety isn't controlled. A lot of the other symptoms aren't controlled. They simply don't have convulsions. It's not, and again, the interesting thing to me is that in the UK, gabapentin has been used in a number of studies, and they say very effectively, even though it's not really recommended as a solo anticonvulsant. All right, the outpatient taper, or long outpatient taper, it's the least dangerous method. You've got the least risk of overshooting or overdosing, and the least risk of seizures, and basically, you basically taper about 10% a week, or even slower as the patient tolerates. The problem is, if you're looking at the studies that do this, they have a high early failure rate, where patients drop out early, because mostly, and if you read the studies in the fine print, you see mostly because you give them, patients would be given a week of medication at a time. They'd come in at day 2 or 3 and say, I've used all my medication. So yeah, that wasn't tremendously successful because of that. And if you're going to do that, you got to pick your patients carefully. And sometimes if it's possible, you give them daily observed doses, or daily prescriptions. Here's your prescription for 3 Valiums. It's a lot of work for the practitioner, but it does. If you look at the long-term success rate, it is the most successful long-term, caveat, for people who complete the process. For the others, all these others, there's a really, we have really good success rates getting people through it, out the door, back to their outpatient, substance use disorder treatment, but their relapse rate within a year is very high. Again, plus or minus an anticonvulsant if you want to do that. Some people say, gabapentin is very popular these days for treating anxiety. I've not found it that effective, but some people do. Maybe it's a patient population thing. All right, then we get to something totally different, which is phenobarbital. Now, phenobarbital is really a paleopharmaceutical. It was, I think it was developed in the 1930s. It's a tricky drug to use because it has, it's very lipid soluble. And that means that the first doses disappear very quickly as they're taken up into the tissue lipids. Subsequent doses aren't taken up as fast. And so what people get fooled into is they think, oh, they give that first dose, they don't see any effect. So they just start piling on doses. And at some point, the lipids saturate. And then suddenly the blood concentration skyrockets. And then you have somebody who is over sedated. So the half-life is extraordinarily long. In studies anywhere from 53 to 118 hours. And the initial redistribution half-life is 11 minutes. So it means if the first dose, that first part of the curve looks like it has an 11-minute half-life. That's how fast it's taken out of the system, out of the blood and taken into tissue lipids. It's, without going into the detail, it really messes up with the hepatic metabolism of a lot of other drugs. It doesn't play well with other drugs. It either hogs the metabolic pathways or it induces metabolic pathways. So anything else that people are taking, especially some of our more modern drugs, which tend to use one of the specific cytochrome P450 enzymes, it can really foul up the blood levels of that. It also has a rare syndrome, DRESS syndrome, I think it has another name, but basically it's drug rash with eosinophilia and systemic symptoms. It's I've seen it once. It's a rash, eosinophilia, no surprise, and just sort of fever, chills, myalgias, and you have to stop the drug for that. All right. It's also specifically contraindicated in certain types of porphyria. Anyway, as I said before, it binds the inside of the GABA receptor, increases the duration of opening, and that's one of the reasons I know people have been talking about using it, especially with the COVID pandemic. People are starting to talk about using phenobarbital for both alcohol and benzodiazepine withdrawal as an outpatient. Considering it, I might consider it for an alcohol withdrawal patient whose alcohol was their only drug, but considering the synergy you're going to get with benzodiazepines, I would be very reluctant to give this to someone who has a benzodiazepine issue for fear that they might try to supplement it with their benzodiazepine and end up killing themselves. All right. So the other thing that the barbiturates do is they block glutamate receptors. So they enhance GABA receptors, they block glutamate receptors. That's what gives them that extra power. So they're really very effective at preventing seizures from both alcohol and benzodiazepine withdrawal. They are also just really, really tricky to dose. You have to be very cautious. You have to go fast initially and know when to slow down. So it takes a certain amount of finesse. It's still widely considered the gold standard for anticonvulsant. All right. So how would you do it? It basically is much like the benzodiazepine taper, where you start by giving them a roughly equivalent amount, titrating to symptoms. There are charts out there that show the phenobarbital equivalent to benzodiazepines. The caveat there is those are only accurate in people who are benzodiazepine naive, so not people who are using benzodiazepines chronically. Taper phase will be longer, need to monitor for a while. It's got some advantages, and the reason I used it is that it's really good for patients who have what I call a high salience to benzodiazepines, because in the detox, we would see, at the end of the taper, people would come, if we were using Librium, for example, people would come at the end and it was just, they were pleading, like, please, can't I have another day, another couple days of that? And because of I think probably because of the glutamate antagonism, nobody wanted to stay on phenobarbital longer. I mean, I had people coming into the office saying, can I get off this stuff a little quicker now? So very different thing. The other thing is once you've given them that loading dose that first day, the blood levels drop very slowly because of the really long half-life and the lipid solubility. So one of the advantages to that, if somebody, you get them loaded up on the phenobarbital and the next day they say, I've had it, I'm out of here, I'm leaving, you don't have to worry because it will self-taper. So arguably the lowest risk of seizures there. All right. All right, again, high risk of sedation, especially with the elderly. There's huge fall risk issues, so you really can't do this in somebody who's already got a fall risk, and hypoventilation. All right. Okay. All right. So what about after detox? Again, relapse rate is high. Again, with most of the taper or detox protocols, we're talking about 40 to 60% relapse within 6 months. For a lot of different reasons, mostly whatever was causing them to want to use benzodiazepines is still there, most likely. And then there's an extended withdrawal, 2 to 6 months, where people can have anxiety, insomnia, tinnitus, even paresthesias. Okay, again, best treatment for it is obvious prevention. I'm not going to pound this too hard, but the majority of benzodiazepine addictions start with a prescription, especially in patients over 30. And the most common reason people are given these prescriptions are for anxiety, panic attacks, and insomnia. Again, the issue is not, they are very effective for that. I mean, benzodiazepines are extraordinarily effective for anxiety, and that's the biggest problem we have with patients who have anxiety, is that if they've had the benzodiazepine, they know, wow, that really works. And if we put them on something else, an SSRI, any other thing, they're going, well, that's not working as well as the clonazepam. Well, no, it doesn't. But it doesn't have the problems with dependence. And the other thing, of course, is that they're not really effective. I mean, they will definitely make people sleep, but their sleep is not as restful, and the rebound insomnia is bad, and also the tolerance to the sedating effect is very quick. All right. And it's one of the things, and then I've spent some time when I was in the Army in primary care, and I know how hard it is when you have somebody who is absolutely convinced that the only thing in the world that's going to fix their problems is a benzodiazepine. How to get them out of your office in 15 minutes or less without a benzodiazepine prescription? Hard to know, but I think the most important thing is really think about before you start it. That it's a trap. They'll be coming back. All right. And with that, I think we got some time for questions.
Great. Thank you, Dr. Layloff, for your expertise on this challenging topic. I can take some questions here online, but perhaps start in the room if there are any comments or questions for our speaker.
Should be some benefit for actually coming here in person. Yes.
Thank you. I really appreciated your talk. We recently admitted a patient with a Fioricet problem, taking 8 a day, and we couldn't find anything on the PDMP. She said she was getting the medicine through the mail, and I'm wondering, Fioricet, I guess, would be a barbiturate,
right.
not
butalbital is the
active. Yeah. I'm curious as to what you've seen in your practice in terms of how much of that is sort of mail order versus on the streets, and whether there is much barbiturate withdrawal needing to happen out there.
Barbiturate withdrawal is really rare. We actually see it because barbiturate prescriptions are very rare, and it's not a currently popular street drug. That could change tomorrow. I mean, the street drugs are kind of faddish, but it's really, I think, because people don't find it as fun as the benzodiazepines. Barbiturates, I've never taken them, but certainly you see people with it. They look very sedated, fatigued, tired, dragged out. They don't have that sort of euphoria that people with benzodiazepines often have. So I don't think it's going to become a thing, but that is the niche, is the Fioricet, butalbital thing, is people, and I've dealt with a few with those. You can use either benzodiazepine or phenobarbital for the taper on that. But yeah, mostly the Fioricet has become, again, another paleopharmaceutical, because it's really people my generation and older that were prescribing it, and we're kind of fading away. And most too also learned that it wasn't that effective a drug for migraines. We got much better migraine medication, but still, especially the mail order pharmacy thing, that's a very, if it's not dark web, it's very darkish web. So yeah, you can, on the dark web, you can get just about anything. I think even heard somebody was selling their immortal soul on the dark web. So
Great, thank you. Any other questions here in the room?
Thank you. I've had a number of patients whose previous physician has retired and who had been on long-term benzodiazepines at pretty heavy doses. And my impression is that those folks are probably never going to completely come off of benzodiazepines, or they're going to have an absolutely miserable life. But as a geriatrician, I obviously have an anti-benzodiazepine bias and worry about all of the adverse effects. How do you go about approaching sort of establishing a relationship and building trust with someone who has this long-standing relationship with the medicine? And what's your sort of approach for harm reduction in that setting?
yeah, this is a question that comes up a lot, really. And in my working with the Grand Ronde tribe, they have a health and wellness center out on the tribal grounds that the practitioners out there have the exact same problem. Is they're getting a lot of folks who are sort of legacy benzodiazepine users. And a lot of times we sit down and try to figure out what's best for them. You know, if you're dealing with someone who's relatively young and who is motivated to stop using them, that's easy enough to work with. We can do a taper and all that. We've had a few of those, very successful. Motivation is a key thing. But you're right, if you got somebody who's 60, 70 years old, 80 years old, and they're on benzodiazepines, and they've been on benzodiazepines since Eisenhower was president, you know, they're not going to stop. And I think, you know, every case is, every situation is different, but I think you have to weigh the benefits versus the risk. I mean, the risk is this person is going to be miserable. They are at a higher risk of a seizure. They're at a higher risk of, you know, if not surfing the dark web themselves, maybe getting a grandchild surf the dark web and get them some. And there are illicit benzodiazepines out there. This is kind of what we saw with in 2013 when the opiate prescribing just suddenly clamped down. Is a lot of people who'd been getting chronic opiates for chronic pain, chronic non-malignant pain, suddenly were pushed out into the illicit market. And so we saw a lot of people who were out there, you know, negotiating for the first time, getting heroin and then later fentanyl. So it's, to me, I would look at it as a cost versus benefit relationship. You know, does that person want to do it? Because, you know, it's very difficult to get someone to, I mean, you can stop prescribing them, but then unfortunately, somebody else wrote the check that you're having to cash here. You know, if you stop it abruptly, you're going to be the one who gets blamed for the seizure. So not a lot of help there, I'm afraid.
Great, thank you. Challenging topic. I'll take a question here. You spoke about the anti-epileptic medications when we're looking to taper benzodiazepines. Can you talk about any experience? You mentioned gabapentin, but also pregabalin for use, not only for seizure prevention, but potentially to help manage anxiety or other withdrawal symptoms.
Yeah, again, I'm not a big fan of gabapentin or pregabalin for anxiety necessarily. I think there's a lot better medications for it. I think gabapentin, especially early on, can be sedating, but people get tolerance to that sedating effect fairly quickly. So I think in a lot of ways, the anxiolysis you get from gabapentin is like the anxiolysis you get from hydroxyzine or Benadryl. You know, you're just looking at some sedation as a side effect, where I much more prefer. But as far as the anticonvulsant effect, again, gabapentin is not a first-line anticonvulsant. It's not a solo agent for seizure prevention, but you know, it's been used apparently successfully for that. I mean, if you have somebody who's on pregabalin for some other reason, like neuropathic pain, obviously just continue with that. Or if you have someone with neuropathic pain, that might be an interesting thing to add there, because not only do you get that sort of sedating effect of the pregabalin, which is, as I recall, less somewhat than the gabapentin, but you also get the neuropathic pain relief, which is more effective in pregabalin than in gabapentin. So that might help reduce some of the other issues that are dealing. But I'm not sure that pregabalin or gabapentin would be my go-to unless I had someone that I really wasn't that concerned about seizures. If I was going to add an anticonvulsant, I'd probably want to add one that works as a solo agent. I mean, we used to use valproic acid all the time. I never liked carbamazepine for a lot of different reasons, lots of issues with it. But levetiracetam, topiramate, a lot of those drugs, the more modern anticonvulsants it seems like a reasonable thing, with the caveat they have not been studied in benzodiazepine or alcohol withdrawal for preventing seizures, but the assumption is they will work.
I wonder if you have an opinion from your perspective about prescriptions for very small amounts of benzodiazepines in the initial treatment of anxiety disorders. I think the psychiatrists are much more likely to do that than we have been in primary care, but sometimes I think it can be very helpful to get reluctant patients to stick with their SSRIs and such. Mm-hmm. And I wonder if you think that's a dangerous thing to do from your end.
Well, it's interesting. There was I just kind of ran across yesterday an article from the APA about, that exact thing. And they found that only about 15% of people who got started with these short courses for anxiety, only 15% ended up continuing to need or take benzodiazepines for a year. So in one aspect, you can, and that sort of reflects my personal experience, is that most of the people that you give, say, six lorazepam to and tell them use this for a panic attack, they'll still have 5 at your next visit in 6 months, But then the problem we see, again, I'm seeing a very selected part of that population, and what often happens is that, I've talking with patients, you'll start with, you'll say, the doctor will say, take this only if you have a panic attack that's not resolving in 15 minutes, which is then almost immediately translated as take this if you're having a panic attack, which then becomes take this if you feel like you might about to be having a panic attack, or you're in a situation where you might have a panic attack, or you might be in a situation that might trigger a panic attack, or it's a day ending in Y. And that's that 15% that just sort of, it's not like they start out saying, I'm just going to snarf all these things down as fast as I can just for fun. They in their mind is very legitimate, but they're so anxious about anxiety that they ended up, so I agree. I think it's very reasonable to give somebody a short, small amount to help them get started on something, on SSRI or something else. But I think you need to be really cautious about the person who comes in 3 days after you give them, a 6-week supply and says, well, I've gone through all of my Valium and I need some more. Yeah, I think there's, as much as I'd love to say we're going to ban benzodiazepines from use forever, I don't think that's a practical thing. I think they are very useful medications, but they're also very dangerous in their own way.
Thank you, Dr. Laidler. In our last couple minutes here, I wondered if you could just tell us a bit more about your work with Great Circle Recovery as an organization in our community to educate us about resources.
All right. Great Circle Recovery, again, was established and funded by the Confederated Tribes of Grand Ronde. They actually started this. It's kind of a funny Portland story too, isn't it? About 3 years ago, they bought 2 pieces of property, one in Salem, one in Portland, with the intention of turning them into opiate treatment programs. Because of permitting issues in Portland, we opened the one in Salem 6 months after that, and the one in Portland just opened in April. So it took a while. It took us 2 years of permitting to get the one in Portland open. But we're both, so this is it's an opiate treatment program. We don't, unfortunately, not right at this moment, we're not dealing with alcohol, benzodiazepines, et cetera, although we do have resources for that. So we have a clinic in Salem on Commercial Street. We have one in Portland at 82nd and Powell, basically. It is open to anybody. It's not limited to tribal members. Although if for tribal members, we do have some more resources we can tap, but we accept anybody who walks in the door. It's no appointment necessary. Walk in. We're open Monday through Friday, 6 a.m. to 2. And again, anyone's welcome to come in. We do. We're in the process. Actually, recently got approval from the tribal council. They're going to fund us to start our own detox program in Salem. So we're going to have medically managed withdrawal for opiates, benzodiazepines, alcohol in Salem sometime in 2024.
Great. Thank you for your work in the community and sharing a little bit more about that. We're coming just up on the 9 o'clock hour, so thank you for joining us again for Medical Grand Rounds. We will be in person next week for the annual Holtzgang Ethics Lectureship. In 2 weeks, we will only have Grand Rounds on Wednesday.